current nomenclature was agreed and published in 2009, but it is revised every year, and if there are any changes, then they are notified. So first of all, we will talk about terminology which involves bladder for urinary incontinence symptoms. So main symptoms we are talking about is urinary incontinence, and let's see what's the definition for that. Involuntary loss of urine. So if you see, it is very, very simple. And simple things are good because we can remember them and we can relate to them rather than talking too much. So just four words: involuntary loss of urine is urinary incontinence. And then what is stress urinary incontinence? We all know what it is, but the way they define it, and they would like everyone to define stress incontinence as involuntary loss of urine on effort or physical exertion, for example, sporting activities, or on sneezing and coughing. A lot of people, they don't understand the difference between stress incontinence as well as overactive bladder. And sometimes in general practice, people use these terms interchangeably. These two conditions are entirely different from each other. So we must know that stress incontinence is something which happens on stress, and it's not mental stress, it's physical stress. Any condition which will increase the intra-abdominal pressure, for example, coughing, sneezing, jumping, laughing, running, and with that activity when there is leaking of urine, that is stress incontinence. Now the next one is urgency urinary incontinence. And what is urgency? When we have to rush to the toilet, okay? If somebody needs to go, they need to rush. Otherwise, there will be loss of urine. So let's see what's the definition for that. Involuntary loss of urine associated with urgency. So what is the definition of urgency? For example, if one of you now needs to go to the toilet, they won't wait for me to finish this lecture. They must go now, otherwise they would have accident. So this is that type of urgency. They are not able to hold it more than few minutes. Okay, so that's what we need to remember. The actual urgency of urine is quite a debilitating problem. And then the next definition we are talking about is postural urinary incontinence. So if you notice, before every definition, the first four words they have kept the same, which is for the urinary incontinence, which is involuntary loss of urine. So if you, for all the students, if you remember these four words, then rest of the definitions, they start with these four words. So it's easier to memorize when you are going for exam or something. So involuntary loss of urine. Oh. Thank you. ठीक. So involuntary loss of urine associated with changes of body position, for example, rising from sitting or lying position. Okay, so that is postural incontinence. So what do you think, what would be the more etiology of postural incontinence? Will it be overactive bladder or will it be stress incontinence, if we have to point to one side? Yeah, so it could be anything. That's why they have not defined it. If somebody has overactive bladder, sometimes there is cough-induced overactivity, and sometimes it is stress incontinence related to change in posture. So we move on to more symptoms. So nocturnal enuresis, which in simple words is called bedwetting. Okay, so like babies, as they do bedwetting in the childhood. So unfortunately, adults can also have this problem, and this is extremely troublesome problem. If somebody is asleep and then they wake up and they realize they have wet their bed, how embarrassing is that? That can break relationships, that can have huge impact on family finances because they have to wash all the clothing, all the mattresses get spoiled. So it's extremely distressing problem, which is nocturnal enuresis. So let's see what's the definition. Involuntary urine loss which occurs during sleep. So in simple words, it is bedwetting, but people think that bedwetting is related only to babies, but it can happen to adults as well. And let's see what's the mixed urinary incontinence. Involuntary loss of urine associated with urgency and also with efforts or physical exertion or sneezing or coughing. So in mixed one, they have joined the both definition of urgency incontinence and stress incontinence. And most of the women who have urinary incontinence, almost 80-90% of them will have mixed picture. So that is the commonest type of incontinence where we cannot pinpoint is it stress incontinence or overactive bladder because they have both type of picture. So this is the commonest picture which we deal in everyday clinical practice. So this is the one you will listen to patients and you will say yes, she has mixed urinary incontinence. The next one is continuous urinary incontinence. Again, they have kept definition, so it's so beautiful. They have kept it so simple and easy for everyone to remember. It is continuous involuntary loss of urine. So what could be the reasons for that, for continuous involuntary loss of urine? Any ideas why somebody will keep leaking continuously? And I'll give you a hint. Think about Africa. Exactly. Well done. So any fistulae, which are a hole in the bladder, which is leaking through vagina. So they have no control. It is not related to coughing, sneezing or urgency. There is a hole. As soon as urine comes in the bladder from kidneys, it will come out, so which is continuous loss of urine. So if you see, these things are so simple, but they are so much relevant to clinical practice. And sometime in urogynecology, you don't need any fancy testing, and just being aware about these definitions, being aware about etiology, you can diagnose the patient sitting there and then. And now next one is insensible urinary incontinence. So when somebody coughs or sneezes, they have leaking, so they are aware, oh my God, so there is some dampness, I've just sneezed and there is some leaking. Somebody needs to go to the toilet, they rush to the toilet, while getting to the toilet they leak, so they know it's urgency. But unfortunately, sometimes you have nothing of that. You don't need to go to the toilet. You are not coughing and sneezing. You don't even realize that actually your underpants or your clothing is wet. So that is called insensible. Without you realizing that there is any problem, and you don't realize, and actually you have become incontinent. Usually insensible loss of urine is small volume, it's not large volume. We'll talk about volumes when we talk about other things. So the main thing is woman is not aware how it occurred, it just happened. Coital incontinence, this is unfortunately one of those things people don't talk about, and this is something which is extremely embarrassing for people. In the UK, women are a bit more aware about these problems, so they don't feel shy. But in India, I don't think anyone would ever tell you they could have this problem, but you need to ask direct questions. Involuntary loss of urine with coitus. This symptom might be further divided, that is occurring with penetration or occurring at orgasm, because the etiology is different for both of them. If you need to ask, as soon as you start, does it happen or does it happen at the end? So if it happens at the start with penetration, usually it is stress incontinence related. This means there is problem with the pelvic floor muscle. But if it happens at the end of the coitus, at orgasm, usually it is because of overactive bladder. So if we know these little things and we further classify, ask her confidentially, then we can find out the cause of the reason. But mostly they would say it is mixed picture as well. So we need to keep that in mind. So we were speaking about symptoms, which was all the symptoms in urogynecology. Now we are talking about lower urinary tract symptoms. So before we were talking about patient's history, now we are dividing our things into storage, voiding, and post-micturition phase. As yesterday we were discussing, the main thing is storage phase and voiding phase, but we did not mention post-micturition phase. So we will divide these symptoms into three, and now let's see. So storage symptoms. So what is storage? That we are supposed to fill the bladder, keep filling it, and only go to the toilet when we really need it. So increased daytime urinary frequency. So what do you think, an adult female, how many times would it be normal for an adult female to go to the toilet in the daytime? What we would classify as normal? Any ideas? Yeah, that's good. Any other ideas? Any other guesses? So if you think about it, when we all wake up, first thing we do, most of us, we go to the toilet. Then we have breakfast, and when we are getting ready for work, maybe before we come out of the house, we go to the toilet. So that is twice. Then we have before lunch, when we have a drink or something, we go to the toilet. That is third time. Then we have lunch. When we pray Dhuhr, maybe we go to the toilet 4 times. Then maybe one time with Asr, then Maghrib 5, and then Isha 6. For us it is easy because we divide our routine with the prayers time. But it is surprising that other people who are not practicing Muslim, and you talk to them, and actually their normal bladder pattern is also similar. So our prayer times are quite physiological. So 5 to 6 times in the daytime is a normal frequency to go to the toilet, and night time going once is normal. So if somebody goes once, that's perfectly normal, and more than one we classify as nocturia. So let's see what the definition tells us. Micturition occurs more frequently during waking hours than previously deemed normal by the woman. So quite intelligently, they have not mentioned the number of times somebody needs to go to the toilet to classify as increased frequency. The reason is that people are different. And why people are different? Because of our intake of water. There are certain people who would not drink more than 1 glass of water in a day. Yeah? And some people, they drink 3 liters of water. So whatever we drink, it needs to come out. So that's why if a woman's frequency all her life has been 5 times in a day, and now it has become 15 times in a day, so which is abnormal. But if somebody from the beginning was going maybe 10 times in a day, and now they are going 15 times, it has changed from the previous. So what they have cleverly mentioned, they have not mentioned the frequency here, but they are relating it to the past frequency, and now if there is a change, significant change in frequency, that's what the definition says. Interruption of sleep, we are talking about nocturia now. Interruption of sleep 1 or more times because of the need to micturate, and each void is preceded and followed by sleep. For example, if somebody says, oh, last night I went to the toilet 5 times, and you would say, oh, actually that's abnormal. But when you ask them, what were you doing last night? They say, we were in a party and we were having drinks. And if then they went to the toilet 5 times, that's perfectly normal, because that's like a daytime. But if somebody said, oh, I went to bed 9 p.m. and then I woke up every 2 hours to go to the go to the toilet, because I couldn't sleep, I woke up because of the sensation of urgency. I had to go to the toilet, and when I came back, I was so sleepy I have to go back to sleep. Because sometimes people are waking up for some other reason and they keep eating and drinking and then they go to the toilet. That is not nocturia. Nocturia is the sleep pattern is disturbed because bladder has woken them up. It's really important to clarify this point, because pathology of the nocturia can be quite complex. So what is sensation of urgency? Sudden compelling desire to pass urine, which is difficult to defer. So the word we use in the UK is dash to the toilet. This means it cannot be delayed. Whatever happens, I just must go to the toilet. I cannot wait. Okay? And this is such a debilitating thing that you do not see what's happening around you. The overactive bladder is very, very debilitating. You just must go. And that is a sensation of urgency. So overactive bladder or syndrome. So what is a syndrome? So they have combined the top things and then they have made the definition. Urinary urgency, usually accompanied by frequency and nocturia, with or without urgency urinary incontinence. 70 times is too much. You can't do anything else apart from going to the toilet. So this happens. So as soon as she passes urine, she comes out and she goes again. Post-micturition leakage, further involuntary passage of urine following completion of micturition. So post-micturition leakage, the another term for this is post-void dribble. You go to the toilet, you have cleaned yourself, you have dried yourself, you have stood up, and some urine comes out. This is called post-void dribble or post-micturition leakage. There is etiology. Can anyone think of that? Why could that happen? You have just finished passing urine, you have stood up, some urine has come out. Maybe some of us has experienced that when we stand up. So what could be the reason for that? So the interesting thing is that with each of these etiology, there is a host of diseases related to it. And awareness is the one which are going to get there. Because what happens when patients come to us with urgency, we give them medication, we do some sort of surgery, and we hope they get better, but they don't get better. The reason is we have not been digging enough to find out, and that is why this lecture is the most important lecture, because then from this you can understand it's not as simple as it seems. There are numerous pathologies which can cause numerous symptoms, and exactly same way there are numerous treatments as well. But first of all, we need to define it and find out. So post-micturition leakage, if nothing comes to your mind, just think about diverticulum. Yeah, it's a pouch of the urethra. So when we pass urine, some urine stores there. Yeah, so we think we are done, we stand up and it leaks. Yeah, so that is one example of post-micturition or post-void dribble. So how beautiful is it that with knowledge we can understand so much. We have not even touched our patient. Just talking to her, we can understand. We don't need machines, we don't need anything expensive, but just the intellect, talking to patient, we can understand what's wrong. Another thing which can come to your mind, which is post-void dribble, could be a fistula again. Yeah, so urine has collected there. It's a small fistula, which is crisscross fistula, so that when she passes urine, because of sitting down, some urine leaks in the posterior fornix of the vagina. So when she stands up, that urine comes out. When it is post-void dribble. Yeah, sometimes it is a prolapse as well. Because what happens with a large rectocele, when she is passing urine, and with large genital hiatus, some of the urine is going behind the rectocele and is going in the posterior pouch. When she stands up, it could be pouch of Douglas urine coming out. So all these things, is just thought-provoking definitions. So position-dependent micturition. Having to take specific positions to be able to micturate spontaneously or to improve bladder emptying, leaning forward or backwards on the toilet seat, or voiding in semi-standing position. So what this means, the normal toilet, for example, if we have an Indian toilet where we squat on the floor, or if we have a sitting toilet, if a woman used to pass urine on that comfortably, but now something has changed. She cannot pass urine, and now she has to do various things in order to pass urine. So what has changed? So this means there is some anatomical change. Yeah, so in this one, when there is position related, some anatomical change has happened. So what that could be? Maybe a Birch-Colpo suspension. Interesting, isn't it? Because what we have done, so in Birch-Colpo suspension, 3 sutures, these are 3 stitches on the side. We have lifted the vagina up with the help of permanent plastic stitches, which has splinted the urethra in a way that it cannot operate in the normal way because anatomy has changed. So woman has to bend forward, backwards, rock side to side. So this could be one of the indication of this type of problem. So we have a patient who only passes urine when she's bending her knees in standing position. So she has to go to her shower and pass urine. How embarrassing is that, and how difficult is that? Because in normal public toilet she can't go. So she has become disabled. She can't pass urine. There is a solution for that. We'll talk about solutions in the further lectures. Okay, so now we are talking about dysuria. Very troubling, isn't it? Passing urine shouldn't be a chore, shouldn't be a trouble. Complaint of burning or other discomfort during micturition. Discomfort may be intrinsic to the lower urinary tract or external, which is vulvar dysuria. So what it says that sometimes the sensation of pain is actually inside the bladder. You have actual pain inside your bladder when you are passing urine, or most commonly you have sensation of pain in your urethra. Yeah, so that is the intrinsic, but sometimes it is outside. The actual coming the urine out of urethra is not painful, but when it touches the vulva it hurts. So it is local sensation of burning outside, which is extrinsic, or inside. So any examples of intrinsic pain or dysfunction is very commonly, it's the commonest thing, isn't it? UTI, exactly. Urethritis, sexually transmitted infection which cause chronic urethritis. So it is intrinsic pain. Extrinsic, as we already discussed, if it is atrophy, vulvovaginal atrophy, lichen sclerosis, which causes itching and soreness on the vulva, or lichen planus, or other skin conditions, or any other local skin condition. So when urine touches there, it burns. Next one is retention. Complaint of inability to pass urine despite persistent effort. Very painful condition that you know your bladder is full, you are trying your hard, nothing is coming out. So that is called urinary retention. Any guesses? What volume do we say, oh, this is retention now, or retention can be irrespective of volume? What do you think? Mm-hmm. Yeah, so I think it is the sensation based. Sometime even if there is 300 mils of urine in the bladder, but if somebody can't pass it, it is quite painful. And sometimes there is 1 liter because of actual problem. So any retention means bladder sensation of full bladder, but you are not able to pass urine. But when somebody mentioned 150 mils, that is post-void residual. We use that terminology somewhere else. When we discuss incomplete emptying of the bladder, then we let them pass urine and then we do a scan, and if it is more than 150 mils, or if they have passed 1/3 and they have kept 2/3. So there is a rule of thirds. So that is also post-void residual. For example, if somebody has 300 in their bladder, they have passed 200, kept 100, that's normal, not a problem. But if they have passed 200, if they have passed 100 and kept 200, that's a problem. Okay, so now we are going to pelvic organ prolapse symptoms, isn't it? Before we were talking about voiding phase, storage phase, urine sensation phase, sensation related symptoms. Now we are coming to pelvic organ prolapse. And again, this is a can of worms, because prolapse is very ambiguous term, and this is so important to standardize this. And this is a good starting point, because only because of these definitions we can do research, we can relate to each other, and we can help patients. So that's why this is vital to know these things. So the first we are talking about is vaginal bulging. So complaint of a bulge or something coming down towards or through the vaginal introitus. So here in India, people will say, "Mujhe boj padta hai," yeah, some pressure is felt, something like that. But in English, it is just a bulge or something coming down and not feeling comfortable. The woman may state she can either feel the bulge by direct palpation or see it aided with a mirror. So that is the main thing. Pelvic pressure, complaint of increased heaviness or dragging in the suprapubic area or in the pelvis. So you are aware about something down there. Some people will say, oh, there is like a sensation of golf ball, or there is sensation of an egg there, or there is some sensation of soft flesh. So these are the various terms a woman can use. And she will say, oh, I had a look and I can see it, or she will say, I have seen with the mirror and there is a bulge there. Pelvic pressure, complaint of increased heaviness or dragging in the suprapubic area or in pelvis. This is an associated symptom of prolapse. Bleeding, discharge, infection. Complaint of vaginal bleeding, discharge, or infection related to dependent ulceration of prolapse. This is really important, because if somebody has prosidentia, which is complete prolapse of the uterus, so the cervix keeps rubbing on the knickers or around the thighs, it can cause ulceration, it can bleed, can cause infection. Very, very difficult to control if there is no facility to operate or do anything about the patient. We'll talk about it, how to solve it later on. Okay, so we continue to do pelvic organ prolapse symptoms. The next one is splinting or digitation. This is a terrible, terrible thing which people feel very embarrassed to discuss. But we all need to address this. What is splinting or digitation? This is related to rectocele or any large prolapse, because angle of the rectum has changed now, so they are not able to empty their rectum easily, and they have to aid themselves by putting their fingers in the vagina, pressing on the bulge. It's a very common symptom, so people don't mention it. Yeah, so this is called splinting. So if we have a name for it, we will remember, and we will try asking patient, when you go to the toilet, is it easy to empty your rectum in one go, or you try to go, nothing is happening, poo does not come out, and you have to put your fingers in the vagina or on the side to press on the bulge in order for the poo to come out. So this symptom has been given name of splinting or digitation. Sometimes patients have to do manual evacuation of stool from their rectum, and that is where digitation is related to, but splinting means pushing. Let's see what the definition is. Need to digitally replace the prolapse or to otherwise apply manual pressure to the vagina or perineum or to vagina or rectum to assist voiding or defecation. So splinting and digitation can also be to empty the bladder, because if there is complete kinking of the urethra, which can happen with procedentia, they cannot pass urine. So they have to push the prolapse back or push on the cystocele to empty the bladder. Low backache. Low sacral or period-like backache associated temporarily with pelvic organ prolapse. So, although prolapse itself is not a painful condition, it does not cause pain, but because of constant dragging of uterosacral ligaments, which are attached to the back, so low backache can be associated with prolapse. So, what is the actual prolapse? The descent of one or more of anterior vaginal wall, apical segment of the vagina, which could be uterus, cervix, or post-hysterectomy, or posterior vaginal wall. Absence of prolapse is defined as stage 0 support. Stage 0 means normal. We are not talking about stage 0 of POPQ or 0.0 of POPQ. That is very different. We are talking about stages of normal anatomy. So 0 means normal anatomy when we are classifying prolapse. Prolapse can be staged from stage 1 to stage 4. So, because this is not about the classification of prolapse, it is only symptoms. So now we move on to sexual dysfunction. Dyspareunia, persistent or recurrent pain or discomfort associated with attempted or complete vaginal penetration. So painful sexual intercourse, this is the definition. Superficial dyspareunia, pain or discomfort on vaginal entry or at vaginal introitus. Yesterday we were discussing about hymen problems, imperforate hymen, very small hymen, or a ring-like hymen. So superficial dyspareunia can be because of that. Recently I saw an Indian girl, she's an engineer, such a bright girl, very, very bright, in excellent job in Birmingham. And she came to me and she said she got married 7 years ago, and since 7 years she has not been able to achieve sexual intercourse. And it was so heartbreaking to see, because I saw and she had imperforate hymen. And I got shocked that she's an engineer, she is so educated. Why did she not look it up? She said, I thought maybe I'm just abnormal or maybe something wrong. And her husband was a very sweet person as well, and he didn't want to cause her any pain. It took 5 minutes to sort that out. So 7 years of pain. With the knowledge, you can help them so much. It took 5 minutes to just excise her hymen, and she was so relieved. So meaning to say, these are small things. With knowledge, we can help so many people. It's like sadka jariya, isn't it? We relieve someone's pain. Whenever they have good symptom control, they pray for us. So that is superficial dyspareunia, and I mentioned just one cause, which could be a hymen problem, but there are many other problems. Estrogen deficiency is one of them. Deep dyspareunia, pain or discomfort on deeper penetration, mid or upper vagina. So deep dyspareunia is a bit complex, because if you think about superficial dyspareunia, it is something wrong with the size of the introitus or maybe estrogen deficiency. But upper vagina is very roomy. It is not narrow unless there is a septum or some problem. But if vagina is normal, particularly if they have a normal childbirth, the deep dyspareunia is mostly related problems in the pelvis. So what could be the reason of deep dyspareunia? Anything comes to the mind? Exactly. So there are multiple reasons. One is pelvic inflammatory disease and endometriosis. These are the two common ones. Or maybe a UTI sometime, ongoing chronic UTI can cause bladder pain and dyspareunia. Obstructed intercourse. Vaginal penetration is not possible due to obstruction because of, as we discussed yesterday, congenital anomalies, septum or various types of problems, or very, very tight suturing after forceps delivery. When everything is edematous, you suture it so tight, it looks at that time good, but later on it can cause problem. Vaginal laxity, complaint of excessive vaginal laxity. Some people say, oh, after childbirth it has become too loose, I don't have any sensation with sexual intercourse, or actually I feel as if I'm passing wind through vagina because it is so roomy and introitus is so big. So wind gets trapped there, and when they stand up, they feel as if they are passing wind through vagina. Can be very embarrassing because they have no control of it. So now we are talking about, we are nearly there, I know it's too long, symptoms of anorectal dysfunction, because in urogynecology we are talking about all three compartments. So anal incontinence, involuntary loss of feces or flatus, fecal incontinence, involuntary loss of feces, which can be solid or liquid, passive fecal incontinence, soiling without sensation or warning or difficulty wiping clean. They have passed their motion, and after that they keep cleaning themselves and still there is more. So they think they can't even clean them enough. Coital fecal incontinence occurs during vaginal intercourse. Flatal incontinence, this can be very embarrassing for people because of social reason, involuntary loss of flatus, but there is something which can be done. So fecal or rectal urgency, sudden compelling desire to defecate that is difficult to defer. Again, it is very socially very embarrassing. Fecal flatus urgency incontinence, involuntary loss of feces or flatus associated with urgency, straining to defecate, need to make an intense effort by abdominal straining or Valsalva to either initiate, maintain, or improve defecation. So this is sort of like obstructive defecation. This is another can of worms. Feeling of incomplete bowel evacuation. The rectum does not feel empty after defecation. This is a typical symptom of a rectocele or rectorectal intussusception. Okay. Symptoms of anorectal dysfunction continues. Diminished rectal sensation. So diminished or absent sensation in the rectum that poo is there and they need to go to the toilet. Constipation, bowel movements are infrequent and or incomplete, and or there is a need for frequent straining or manual assistance to defecate. So there is some criteria we can talk about later. Rectal prolapse, external protrusion of the rectum. So we can see it. Okay, we move on to lower urinary tract pain and or pelvic pain. So bladder pain. So this is what I was talking about, bladder pain syndrome. So what is bladder pain? Suprapubic or retropubic pain, pressure or discomfort related to the bladder, and usually increasing with the bladder filling. It may persist or be relieved after voiding. Urethral pain, pain felt in the urethra, and woman indicates the urethra is the site of the pain. Vulval pain, pain felt in and around the vulva. Vaginal pain, pain felt internally within the vagina or above the introitus. Perineal pain, pain felt between the posterior fourchette, posterior lip of the introitus and anus. Pelvic pain, pain perceived to arise in the pelvis, not associated with symptoms suggestive of lower urinary tract, sexual, bowel, or gynecological dysfunction. It is less well defined than the above types of localized pain. Pelvic pain, have anyone heard the word central sensitization syndrome? No? So it's a very complex entity because in UK there is a separate department which is the pain department. So they deal with pain. Doesn't matter from where the pain is coming from. So their job is just to deal with the pain, chronic pain. So there is an entity which is called central sensitization syndrome, but because of various reasons, somebody had pain. For example, somebody had kidney stone, they have like ureteric stone, they had a lot of pain. So that episode is over, they got rid of the stone. But the nerves in the pelvis got sensitized to the pain that they got so stimulated that even after the pathology is gone, pain remains there. So this is called central sensitization syndrome. And now there is a lot of work being done knowing that actually the actual event was gone, but because of sensitization of the pain system, this pain is not going away. So there is a pain modulator group. You might have heard gabapentin and that type of group, which we can use to deal with this type of pain. Or there are certain injections which we can give. Cyclical menstrual pain. Cyclical pain related to menses that raises the possibility of a gynecological cause. This is obviously a common thing we deal with. And then pudendal neuralgia. That is a disturbing one. Burning vaginal or vulval pain anywhere between anus and clitoris, and pain associated with tenderness over the course of pudendal nerve. It's quite disturbing and very difficult to treat. Urinary tract infection, how do we define? Scientific diagnosis of a UTI is the finding of microbiological evidence of significant bacteriuria and pyuria, usually accompanied by symptoms such as increased bladder sensation, urgency, frequency, dysuria, urgency urinary incontinence, and or pain in lower urinary tract. So we actually sometimes we overdiagnose urinary tract infection. There is actually no infection. So there are two parts to diagnosis. One is patient symptoms, that she has pain on passing urine, there is pain in the bladder, there is temperature, there is lower abdominal pain. And second part is lab diagnosis, which is the first part is dipstick. So dipstick we'll talk about. Then we need two things to diagnose on the dipstick, not only one thing. So one is very high number of white blood cells or pus cells, and the second thing which must be present is presence of nitrites. Okay, so you must remember, if nitrites are positive, that is highly indicative that this urine sample needs to go to lab for culture. So we always focus on nitrites along with white cells and with symptoms. Recurrent urinary tract infection, at least 3 symptomatic and medically diagnosed UTI in the previous 12 months. So recurrent, the definition is 3 episodes in 12 months. The previous UTI should have resolved prior to further UTI being diagnosed. Otherwise, it will come in chronic UTI. Okay. Other related history like hematuria or catheterization will assist in diagnosis. Okay, then that was all the symptoms related definitions. Any questions? So many problems. So before this lecture, you would think the urogynecology is quite simple and straightforward. So that's why there is a full committee. Can you believe, like 16, 17 consultants, they sit together and they define these things to make very, very simple definitions so everybody can understand, even with no knowledge